Welcome to my talk. It's called Linguistics meets Narcotics. I'm going to be talking about the language of the opioid crisis. Alright, so in the next 45 minutes or so, I'm going to be talking about the opioid epidemic, and then I'm going to give you a preview of my research. So I'm going to give you a very wide, big umbrella overview of what I do, and then give you some preview of ongoing work that is being done right now, and I'm going to end with some implications, and we might have time for questions. Alright, so chronic pain is a condition in which your pain sensors are continuously being activated, right, by your brain, and so it can be very debilitating. Right? It can refrain you or stop you from being productive. And so the United States government started looking for solutions for this because it's pretty much causing shortages in American workforce, right? And people are in pain, they can't live their lives productively. And one of the solutions that people came up with are opiates, right? Opiates are strong painkillers that have euphoric effects, right? If you take them for other things that's not pain, right? And so opioids ended up as an addictive medication, which is why we have the crisis today. So what you're seeing on the screen is the distribution of opioid-related fatalities in California, where most of this study is based, right? I mean, I guess we can all agree that even though most of this study is in California, it pretty much previews the entire United States because the opiate crisis is everywhere, right? Let me show you how California compares to Arizona. It seems like California has it way worse, right? However, this doesn't really tell us anything, because if we look at the population in California versus the population in Arizona, so let's adjust for every 100,000 of the population, we see that actually it's getting worse in Arizona than it is in California, right? But the thing is, it's getting worse everywhere, right? So just kind of to give you a context. So let me run down the history of the opioid policies in the United States and in California, but know that even though I'm talking specifically about California, this pretty much reflects all the policies everywhere, because opiates and pain are one of those issues in which, whichever side of the aisle you are politically, they agree, right, in the issue of opiates. And so in 1986, the World Health Organization released the analgesic or pain ladder, which talks about the use of opioids for treating cancer pain. So that's where it all started, advocating for treatment for cancer pain. And then in 1992, the Agency for Healthcare Policy and Research advocated for the use of opiates for post-surgery pain. In 1997, California passed the Patient's Bill of Rights. It talks about the use of opioids for non-cancerous conditions. Are you noticing a pattern here? Right, we're going wider and wider. When we talk about non-cancerous, we talk about anything that's not cancer, right? Night sweats is not cancerous, right? All right, and then in 2000, California passed the Intractable Pain Act, and again, this is referencing a lot of federal policies, so even though I'm showing you California, this is pretty much happening everywhere. The bill says a physician and surgeon may prescribe or administer controlled substances for intractable pain. And then in 2007, they amended this policy. They added the word dispense, because they were like, well, these verbs are not enough, let's add another one, right? And then they added the words dangerous drugs and then the coordinating conjunction or, which creates some sort of equivalency between dangerous drugs and controlled substances. And then they added more uses for opiates, right? They added for the treatment of pain, including but not limited to intractable pain. So when you say something is included but not limiting to, that just opens it up for anything, right? All right, and then it got so bad in 2011, deaths from opioid overdose exceeded the deaths from car crashes. And that's when the CDC, or the Centers for Disease Control, declared the opioid epidemic. Fun fact, is actually Centers for Disease Control, because a lot of people say center. It's plural. I don't know why I'm telling you that, I don't care. All right, okay, so this entire picture of the opioid crisis lends itself into investigation, which is why I position my study in this field. I'm looking at the opioid crisis, particularly the three main stakeholders involved in the entire narrative of this crisis. We have the policymakers, the patients, and the physicians, right? So for policymakers, they're important to look at because the language that they use in policies can affect how people on the ground are understanding and enacting these policies. So for that part of my study, I'm actually looking at written data because I'm looking at policies. And then I look at the language that patients use to express their pain. Because chronic pain is actually not something that you can measure. It's also not visible. You can't show up to the doctor and be like, I have a cut or a bruise, I'm in pain, right? Chronic pain doesn't work that way. And so patients rely on their speech or sign to express their pain. And this, in the same light of that, physicians also rely on patients' linguistic manifestation of pain when making prescribing decisions. Right? So for that one, I look at spoken data and I focus on pretty much the entirety of the speech of the patients. And then after that, I look at the physicians because when the crisis got worse, all these studies came out that talks about collaboration is the key for solving the crisis, right? It promotes alternative medications for pain that's not opiates. So there's this push for physicians to maintain this collaborative relationship with their patients. But then at the same time, you have all these restrictive policies that forces physicians to take away the opiates from their patients. And so it's almost like saying, we need to get along, but I'm taking your medication from you. So the physicians find themselves in a position that they have to negotiate between maintaining collaborative relationships and enacting disagreeable policies. All right, so for that one, I also look at spoken data. Although I use different versions of discourse analysis, the main analysis that I conduct in all of my studies here is discourse analysis. It is the study of language beyond the syntactic level. It also is a process of making sense of the motivations and meanings behind the use of certain discourse features of linguistic choices. It's pretty much a very systematic approach, right, to meaning making. So when I was thinking about this, I started thinking about, okay, so what do policymakers say when they're trying to address this issue, right? So I started with this broader question: which linguistic trends emerge from opioid policies as a result of the epidemic, right? So I looked at 223 California policy documents, that's around 110,000 words, from 1970 to 2019, because I had to stop at a certain point. And yeah, so this is kind of like one of the older studies, and in 2019. Methodology that I use here is corpus-based discourse analysis. Just kind of like a brief overview, corpus analysis is that process that allows you to discover the trends, right, that you have in a massive amount of data. And then it also involves a quantitative textual analysis that I'm not going to bore you, but you can access this in an article that I wrote in Discourse Studies and in Applied Corpus Linguistics. Right, so you can learn more of the methodology there. And then discourse analysis is when you actually look at the finer semantic discourse that is not revealed by these bigger picture data that comes out from the corpus analysis. Right? All right, so when I was looking at the corpus, what showed up what pretty much emerged is that there's these patterns when it comes to modal usage. So modal verbs are verbs like shall, must, could, can. These are modals that are pretty much ambiguous. They're polysemic in nature, right? And let me show you why. If you say that the physician may prescribe opiates, you're pretty much saying that the physician has the permission to prescribe opiates, and at the same time you are saying that, yeah, it is possible for the physician to prescribe opiates. You don't really know which is which, right? And then when you say the physician shall prescribe opiates, you can either be saying that, yeah, the physician has this strong will to prescribe opiates. And then similarly, you might not even really know, you're just predicting. Oh yeah, I predict that the physician will prescribe opiates, right? And so it's kind of puzzling why it's being used in policies, considering that it can be ambiguous. So I tend to focus on...
agree that it was...
Sorry. I tend to focus on that because I was like, well, these little words might have some large impacts going on here. And kind of to give you a put this in context, right? Here's an example of a video where people are debating the meaning of shall in a very important whistleblower Congress hearing.
Can we agree that it was urgent?
It was urgent and important, but my job as the Director of National Intelligence was to comply with the Whistleblower Protection Act and adhere to the definition of urgent concern, which is a legal term.
And to adhere to the meaning of the term shall.
Yes, sir.
In this case, you sought a second opinion on whether shall really means shall by going to the White House.
Well, sir, I have to work with what I've got, and that is the Office of Legal Counsel within the executive branch.
Well, what you also had was a statute that says shall, and even then you said you had the discretion to provide it, but did not.
Because it did not meet the matter of urgent concern.
The law that Congress, that this very committee drafted, really couldn't be clearer. It states that upon receiving such an urgent complaint from the Inspector General, you, the Director of National Intelligence, quote, shall, end quote, forward it to the Intel committees within 7 days, no ifs, ands, or buts.
The law on the whistleblower statute says you shall share if it's decided to be an urgent concern. Do you see any reason, negative impact on the intelligence community if that legislation was changed to say all whistleblower complaints should be shared with the committees?
That's correct. In addition to that, Congressman, I mean, let's just say the allegation was made against a member of this committee.
And I ask that because I don't know why, when the statute was written, that it didn't say all should be shared rather than only.
So even if you don't know what's going on there, it's kind of clear that they're arguing about the meaning of this one word, right? And so if that doesn't convince you that this modal has a lot of implications in it, I don't know what though. But yeah, so here's an example. So this is what, when I started looking at the corpus, I see stuff like this. So this is the Health and Safety Code, California. It says that the Department of Justice, in 2002, it says they may release the patient's opioid prescription history to the physician, and then 12 years later, it was amended to say shall. Right. So I was looking at these two policies, and I'm like, okay, well, these policymakers, they're getting paid taxpayers' money, right? They show up to work and they're like, okay, what are we gonna do today? We're gonna address the opiate crisis. How are we gonna do that? Let's change one word from the policy. Let's change may to shall, right? So that's when I changed my research question to a more specific question, which is what roles do modals play in the framing of opiate policies? Why are they so important to the point where policymakers are changing this one word to create an effect, right? And so this is a lot. This might be a lot right now. But let me just kind of gloss through this. What you see here is the scale of modality scale where you have all the modals, the positives and the negatives. So what I did was I went through a lot of literature on modality, and then I mapped the modals in this scale, right? To kind of to show you where the more restrictive and the more permissive are. These are in relative terms, meaning some people might argue that would and will, for example, one might be more restrictive or permissive than the other. However, I think most people can agree that will is very different from can, right? So that's what I'm trying to show here. Their permissiveness and restrictiveness are relative to each other. So what you see here is that as you go to the far ends, the policies are becoming more restrictive, right? And as you get into the middle area, it's more permissive. So I pretty much looked at the policies and compared them to this scale to see where the entire policy is, where the entire state is in terms of combating the crisis. All right, so for this example I showed you earlier, we see a movement from a more permissive policy to a more restrictive policy, right? So it seems like policymakers are putting some weight, right, into the meaning of these words to the point where they are willing to change them. In the sense that they're saying, yeah, may is not enough, let's change it to shall. Here's my favorite example, just because it's very subtle. You have, in 1994, it says that a physician assistant may not administer opiates. And then in 2017, it switched to shall not. Now, I don't know about you, but if someone tells me if I tell my students you may not cheat in the exam, I hope they're not reinterpreting that as you may cheat in the exam, right? I mean, I probably would not cheat in the exam if someone tells me you may not. But I don't know about you. Do you think there's much of a difference between may not and shall not? Because here's the thing, adding the not in the may already takes out or weakens the possibility that comes with the may. But yet, that's still not enough. Policymakers were like, well, let's limit that even further and take out the may, replace it with shall, right? And further limit that interpretive space in which these policy actors can act, right? And so what you see here is a movement from may not to shall not, such a small movement, right? But the policymakers find it to be something that they have to do, right? So by tracking modal uses across time, you can see here the blue line are the restrictive policies and the orange line are the permissive policies, right? We can see that policymakers are using more restrictive, or the blue dots, right, or more restrictive clauses as the opioid crisis worsens. All right. And we see this in different patterns as well. So if we look at restrictive and permissive policies against time, for example, we see a positive, actually significant relationship between time and the use of restrictive clauses with our p-value. If it's less than 0.05, that's significant. We also see the same pattern when we look at fatalities versus the number of restrictive and permissive modality, right? The positive slope for the restrictive policies, they're significant. And if we just look at the amendment, so that's something I looked at too. For every amendment, is it becoming stricter or more permissive, right? And what we're seeing here is that it's becoming more restrictive. Now, to show you how I conducted the discourse analysis, where I actually get into what these policies are saying, right? Through discourse analysis, some of the contextual information became more obvious. For example, who are the addressees of these policies? So it seems like most policies are addressing healthcare providers, and then the other half are addressed to state employees. So when we talk about state employees, we're talking about enforcement, state diversion efforts, so workers for the state that deals with rehabilitation and stuff like that. So just remember, the blue one is healthcare providers and the orange one's state providers. So if you look at this graphic or this moving graphic right here, right, in the beginning there seems to be more bias in the distribution of restrictive policies towards healthcare providers. And it just so happened that in 2011, when the CDC declared the opioid epidemic, the distribution became insignificant, right? So how do we interpret significant and insignificant distribution, right? So when we talk about significant distribution, we're talking about when the opioid crisis was beginning, most of the policies were biased towards healthcare providers, right? The restrictive policies are more likely to be assigned to healthcare providers. Now, when the statistical distribution became less significant or not significant, it meant that the distribution of restrictive policies became random. And that's good, right? Because if there's a random distribution, that means that the state has become more of an active participant in the opioid narrative. They are being more involved, right? Policies are being distributed evenly. And aside from that, it also tells you that the opioid crisis is not a concern that's limited within the hospital walls anymore. It is something that involves the outside too, and that's where the state comes in, right? And so by just looking at modality, by looking at modals and then coding who are being addressed by these mays, cans, shalls, and stuff like that, you can actually tell, or kind of get a bigger picture of what the policies are saying. It's kind of like a streamlined way of looking at policies. Like if you're in a hurry, you can just kind of, do that. Now, I also looked at the actions, right? So if we have the addressee, we also have the purpose of those policies. Like, what are those policies saying, right? And these are the ones that emerge, right? So when it comes to addressing pain, most of the policies we're talking about, handling pain, prescriber education, prescriber guidelines, these are all involving healthcare providers, if you notice. And then if you look at the blue side, right, addressing the crisis, you're talking more about the state employees here. When you're talking about diversion programs, right? When you're talking about police enforcement, for example. So if we look at the distribution between those policies, you see here that the orange one, which is the one for physicians, were the predominant policies in the beginning. Makes sense, right? I mean, when the opioid crisis started, it really was a lot about the physicians, right? And then as we go higher and higher, in terms of years, right? As the opioid crisis worsens, we see a more active participation from the state here. So it kind of justifies the pictures that we were seeing earlier. Now, I know I kind of just glossed through that, but I'm gonna go ahead and end that part of the modal study. So, all in all, policymakers are using these modalities obviously to call attention to the gravity of the crisis, right? The positive correlation between restrictiveness and the use of modals are statistically significant. Also, it shapes the interpretive spaces in which stakeholders can operate or negotiate. And I know I'm getting really deep into the terminology now, but if you are interested in interpretive spaces, I also wrote about them. Right. So, the bigger picture, understanding modalities, discourse function can actually inform us of policy developments, right? And can address various local concerns. I am using it here for opioid policies, but you can do that for almost anything, right? Just looking at the modality, right? It also streamlines big picture policy analysis. All right. So let's talk about patients, right? How do patients talk about pain? And some of you, I know some of you have seen this particular study before, so I'm just gonna try to gloss through it. Right, so I asked, what are the context-specific prosodic, what are the context-specific prosodic linguistic choices employed by chronic pain patients? It goes back to the question of like, how do they express their pain? So my methodology for this is prosodic discourse analysis. The prosodic analysis is just kind of like studying the overall pitch and sound and the modal utterances. And then the discourse analysis is again similar to the earlier study. It kind of gets into the context of what these discourse functions are. This is an example of spectrograms, right, of the word bad. This is actually from the same patient. The word bad right here on the left one is the creaky version. If you can see there's no pitch, this is the pitch. The line, there's no pitch. It's really difficult to detect pitch in creaky utterances because it's very low in your register. So that's why the creak happens, right? You go very low to your register that those cracks happen. You see the periodic cracks here. Just pretend you're seeing it, right? All right, there. I'll go ahead and move on. Does anybody not know what vocal fry is? Just to help you out, I recorded a video of myself doing the vocal fry because I know I'm gonna be hoarse. And I'm talking loud, so I'm like, my throat's gonna be dry. All right.
Right as always. Right as always.
That's an example of vocal fry. Thank you very much. You're welcome. So what I'm looking at here is intra-speaker variation. This is register shift by an individual employed in different contexts. So what do I mean by that? If we have a person talking, right, we get established some sort of baseline, which is the average pitch of that speaker, and then we look at marked utterances, meaning those utterances that deviate, right, deviate from the baseline. All right, so let me, I'm gonna play this. I'm gonna play an audio, just kind of pay attention to where the low pitch and creak happens. The low pitch will, I think it's gonna be colored green, and then the creak is underlined. Oh well.
little bit about the pain that you're having right now? Is that it's?
Oh yeah, I woke up crying last night. It's still all up here in the shoulder,
Okay.
but it's in a lot of pain.
All right, I'm gonna move on. I think some of you already heard that example. I really like this example because there's actually a lot of medications that's used here. So the patient talks about Cymbalta, which is not an opiate. This patient also talks about what else? Neurontin, which is not an opiate. So the opiate here is the dilaudid. Right, so kind of pay attention to the build-up to that part of the conversation.
Just a few things. The Cymbalta that, I don't remember his name, the last doctor I
Yeah.
saw, the Cymbalta.
Yeah.
I don't have any more, and there's no refills, so.
Oh,
sorry
okay.
about that.
I can certainly refill that for you if that seems to be helping.
Okay, yeah, I think it does help a little bit with the anxiety and stuff. I
Good.
don't know if it's helping with the pain.
The effect on the pain might be sort of subtle. It's not
Yeah.
as fast acting as some of the other pain medications where you notice the effect right away. But it may be helping to reduce the amount of other pain medicines you require. It's possible. In
Yeah,
any case,
because I did pretty good, I think,
good.
with the dilaudid that they did give me. And also, I take the Neurontin 3 times a day. I really have a hard time remembering to do that 3 times a day all the time.
Yeah, that is hard.
And I have taken Lyrica before, it was just a 2-week trial.
All right, I do not have time to play it again, but hopefully you kind of seen the distribution, and very subtle too, right? So this kind of analysis is actually very subtle. You have to go look at the sound waves, right, and make sure that the pitch is there. Wait, do I? Okay, so this just shows kind of the distribution of utterances that are coded as chronic pain or opiates, meaning they're about chronic pain opiates. Those are the purple ones. And then you have the other pain, which is the orange ones, and then the non-pain, which is the blue ones. Kind of gives you an idea that when you're not talking about pain, the pitch is, or the baseline is usually higher. And here's looking at it through semitones because it allows for kind of inter-speaker variation, so you can actually compare them. You see here the describing or expressing pain. Patient's pitch would go way down. And then you see here where they're requesting for opiates, it would really go down. And remember, these are patients coming into their appointments knowing very well that the opioid crisis exists, right? Knowing very well that their cry for help might be seen as drug-seeking behavior. Right? And so they know coming in there that they have to perform, right? Whether or not they're actually thinking about it or not, right? The idea or the climate exists, right? And people are very aware that their medications might be taken from them. And then if you look at all other utterances, which is pretty much almost everything else that's not those two, right? You see it's kind of a little above average, which makes sense. This is pretty much almost everything. So if you lower these two, the everything else goes up, right? All right, so what I found was participants were using creak and low pitch as context-specific features for narrating symptoms, describing pain, and requesting opiates. By context-specific, I mean that they are very specific in where they produce those creak and low pitch. I did not play an example of the opposite when they're not talking about pain, but I'm pretty sure it's somewhere online from a previous presentation. And if you are more interested, you can also check out my article on this one, shameless plug. But yeah, it's very situational. It really tells you how the use of voice informs us about the linguistic ways in which patients talk about their pain and the ways they engage in delicate discussions that are morally fraught, right? Medical issues, morally fraught medical issues in light of the current epidemic. Right. I'm gonna skip that. And so recognizing the discourse functions of low pitch and creak make you physicians about patients' discomfort. It can also alert physicians to steer back the conversation to talking about shared goals, right? Because that's what has been found to have some success, not a lot of success, but some success in reducing inappropriate opiate prescribing. Right? I've actually talked to a lot of physicians. Obviously, I didn't tell them that I was looking at patient's voice, right? But some of the physicians that I've been working with after I published the article, they would tell me like, oh yeah, I'm actually noticing that my patients are really trying to mark when they're talking about opiates in comparison to talking about asthma or other pains, right? Or when they're requesting for opiates in comparison to requesting for antihistamines or vitamin D, right? And the thing is, it's always been there. It's almost like stating the obvious, but because physicians, they hear it all the time, it becomes the norm to them. They don't really pay attention to the subtle differences between the two. Plus, they have so much more to think about, right? And so, but now they're becoming, at least the ones that I've worked with, are becoming more alert in terms of that issue. I'm going to move on to the third part of the study, which looks at physicians and the linguistic features that they use when they are enacting restrictive opioid policies. This one is interactional discourse analysis, or just literally discourse analysis. I was using discourse analysis to identify physicians' discourse strategies. How do they systematically organize these strategies? And so here are the policies that I observed, right? So all the doctor-patient interactions I looked at were during the time when these three policies were being implemented, so they're pretty new at that time. So they started monitoring for drug tests. They're making sure that the patients are actually taking the medication, right? So they want a positive drug test. Co-prescribing anti-overdose medications, so naloxone or Narcan, right? So they're co-prescribing them. And then they're also being told to shift patient treatment towards alternative ways of dealing with pain, right? So these are the policies that physicians had to bring up in front of their patients. So imagine how awkward those conversations could be, right? And so I really wanted to know, so how did these physicians bring up these topics, right? So to address these issues. So I found that physicians use various strategies to maintain or save face. By face, I mean positive social values derived from what has been approved by society or the ones in power in society, right? First example that I'm going to share with you are the use of pseudo requests. These are imperatives or mandates that are presented as requests or suggestions. And you can go ahead and read the first example. Of course, I made you read it because I had to drink water, right? So in this example, by the way, these are different interactions from the one earlier. So every study, I'm using different data. So for this one, Dr. B said, my instruction for you today is that maybe you have time to go upstairs to do some quick labs. What are you noticing in this directive? So you see, Dr. B started with a declarative sentence. And we have a shift, right? The introduction of the word maybe introduced some optionality in there, right? Maybe, and then it switched to interrogative, right? You have time to go upstairs to do some quick labs? So pretty much the doctor went from telling the patient to do this to giving the patient the possibility of saying no, right, to the directive. In that way, the physician is hedging, right, to soften the blow of implementing or enacting the policy. And then here you have Dr. A. I'm not creative with pseudonyms, so I just use letters. So Dr. A says, okay, they're also going to give you the flu shot, and we'll have to do a urine test. Is that okay with you? Notice the use of urine test is not toxicology test, it's not drug test, it's a urine test. It's not labs, right? The use of the words flu shot and urine test near each other, so they're almost being made to be near collocates, right? You're trying to kind of frame them as something that can be compared. Not necessarily the same thing, but at least in that kind of comparative realm, right? Oh yeah, you can also do the urine test. At the same time, you can do the mundane every year we do annual flu shot, if you take the flu shot, right? And then the use of the inclusive pronoun we, and then have to do, right? It's like introducing this necessity in there. So it softens or mitigates the directive, but also at the same time, pushing some necessity in there. Here's another rhetoric device that I found. It's called impersonalization. It's actually more on scientific writing. It's used to frame subjects as if they could have been anyone else. So in my paper, I argue that it also exists in spoken discourse as a specific form of hedging. So here we see an example of Dr. B. Dr. B says, naloxone reverses an opiate overdose. It's just that no one really plans for an overdose, you know? In fact, what I tell people is that you could help rescue someone who's had opiate or an opiate overdose at home, or even heroin overdose in the streets in your community. So what's happening here is that Dr. B is trying to separate the patient from the narrative, right? By using no one and someone. So pretty much Dr. B volunteered this information about naloxone without using the patient as the agent, right? It's not saying like, oh yeah, you need this because you might overdose, which is essentially what the policy is telling the physician to do, right? Co-prescribe naloxone because they might overdose, right? So the physician's handling this delicately. So kind of erasing the agent here, no one, someone's very vague, right? And then the doctor saying, I tell people. It broadens the audience of the policy. I tell people. I actually talk more about broadening in that same article. I won't have time to go through that right now. And then even heroin overdose in the streets. What I like about this is that Dr. B employs both impersonalization to separate the patient from the one who would overdose, right? And also separating the patient from the one who could actually be helping people by using a vague agent, right? So the participant or the patient just becomes kind of like a side participant in this narrative, to the point where like Dr. B is framing patient B as someone who could save rather than be saved. That's what I really like about this use of rhetoric device here. It's because it kind of switches it around, right? When I heard that, I was like, oh, that's really good. So I found some more, and if you're interested, they are all out there. But to kind of put this all together, right? So the bigger picture, understanding the difficulty of enacting these policies, because physicians are really having a hard time enacting them, right? It opens up opportunities for interdisciplinary studies, especially for between physicians and linguists, among others, right? And it can help in providing some guidance on both the what and the how of policy enactment, because when we talk about policies and policymakers, they don't really talk about how it's enacted on the ground. They leave it, right, to the local levels and how they implement these policies. In fact, they leave it to the local level on how they interpret these policies, right? So they don't really get much guidance, and that's a combination of because of their status too, right? We don't like being told how to do our jobs. Right? That's why when I was working on this, I was working with physicians so that I bring my ignorance into the conversation and then they bring their expertise into the conversation. So if you come up with something deliverable, like something that you can actually use, there's not going to be a competition between like, oh, well, you're just a linguist, right? So like, how can you help? Right? You avoid those kinds of discussions because you're working together to get to that answer. Makes sense. All right. Pretty cool stuff I'm working on recently. I've been looking at patient-physician interaction, and I wanted to know if there's a correlation between patients' race and physicians' opioid prescribing practices. And the reason why I wanted to look at this is because there have been studies that show that physicians' unfamiliarity with the linguistic practices of various cultures could actually lead them to disregard a person's cry for help as drug-seeking behavior. Now, if you don't know how different cultures reflect their pain, right? I mean, we all rate our pains differently, right? My mom gave birth 4 times. She can handle pain, like, I don't know, way more than I could, right? I'm probably not gonna admit that, if I go to the doctor, right? Rather than saying 8, I'll probably say 6, right? So, studies have also cited providers' mistrust of Black patients, for example, that they would misuse opiates, which provides them justification to not provide them with medication. And so I'm going to show in this study why that's problematic. So what I did was, this is a huge process, coding 171 interactions from 2006 to 2020. All of these interactions happened in the United States. All the patients self-identified in terms of race. And I did some statistical analysis too. It's a lot of interactions that I had to go through, so I'm really thankful to my undergraduate students at that time, back then, who helped with the coding process, particularly the ones who worked with me in the lab. So I trained them, and then they did some work, and then I checked their work. And I'm still checking their work because it's a lot. I've rechecked 171 interactions twice. I'm on my 3rd. Because I'm just like, I don't know. I think it's just me. I have a problem. I was like, I need to make sure everything's covered and clear before I move on. So this is how the methodology looked like. So I came up with this coding booklet that talks about like what's a request, what's a prescription, blah, blah, blah. Pretty much when you have a conversation or doctor-patient interaction, you end up with this. You ask whether or not the patient requested opiates, because sometimes they don't even need to request to get opiates. And then yes or no, and then were they prescribed opiates, yes or no. If it's a no, they did appeal the rejection, because there's also a significance in who can appeal, who feels like they can appeal, right? Who feels like they can say something about it, who feels like they can push back to against the doctor. So yes or no, and then if they answered yes, was the appeal successful? Yes or no? And then, obviously there's a lot of findings because there's a lot of permutations here. I'm only going to show you the significant ones, or at least the statistically significant ones. So I found that white identifying patients are more likely to receive opiates even without requesting. So when they come into the doctor-patient interaction complaining about pain, they get to be trusted more and prescribed with opiates. Another significant finding is that requests made by people of color are more likely to be rejected. And then appeals made by people of color were more likely to be denied. Right? So they appeal and then they deny. And a lot of them don't even appeal, right? So those are the statistically significant findings. And there are other insignificant findings. But yeah, I don't have that class right now. But what these findings tell us that, it reveals the inequalities in healthcare, right? It also informs us about the attitudes that physicians have based on the diverse way of representing pain. There is also this connection between how you look like and how you project yourself with how other people perceive your pain, right? And obviously, how we look like will affect that, right? I think that's kind of just common sense. And then adding context to the narrative, framing the crisis as predominantly affecting white communities. I hope you're aware of this. So there's been this narrative, right, that the opioid crisis is a problem that's affecting white communities, which is why there's whole debacle on like why is it being addressed now, but no one's addressing the crack epidemic, blah blah blah. But here's the thing: by framing the opioid epidemic as a problem disproportionately affecting white communities, people of color are implied to be fortunate that inadequate healthcare has enabled them to overcome that crisis, right? It's the same thing, like, oh, it's a white person's problem. Well, because you were lucky you didn't get the medication, so you weren't addicted to it. But why is that problematic? Well, that narrative could actually hinder pain patients from receiving care, forcing them to use deadly illegal alternatives that they can find elsewhere, right? Like when you get opiates from the streets, you don't know what it's laced with, right? It could have something that could kill you in there and you don't know, right? You risk it just to kind of fix your pain or fix your fix. Huh? Right, did you get that? So it could also impede certain communities from accessing diversion and rehabilitation resources. How are we with time? We're doing good with time because I'm trying to delay so that we don't have enough questions. I'm kidding. Those watching this on YouTube, please like and subscribe. All right. So just to wrap this all together, now I can breathe because like I'm towards the end. Right. As an applied sociolinguist, part of what I really do is to arrive at a deep level of understanding on how the most mundane words make the most substantial impact. Right. Let me just go back really quickly with the modals. Right. I've received questions. And I love those questions. They're like, did you ask the policymakers if they did that on purpose? And I'm like, do I really have to? But I did. I tried. They didn't respond. They've retired, right? But here's the thing. If they did it on purpose, let's change may to shall. That means they are putting some weight into the difference between may and shall. The opposite, if they did not do it on purpose, it's the same thing. Subliminally, they are putting more weight to these more restrictive policies. That's why I didn't really need I didn't feel the need to do that. Because then that's really not discourse analysis because you're explaining how you're asking for how the explanation from the other person to interpret the data for you. So that's an example, right? And then when we talk about voice, we don't really pay attention to how people speak sometimes. Like we don't pay attention to how people express their pain. And no one probably even knows that physicians rely on how patients talk about their pain when prescribing opiates, because no one talks about it in that way, right? We don't talk about language and words. Every day when we wake up, we don't be like, oh, I'm gonna talk like this today, right? Except if you have something very specific that you have to do. And when it comes to physicians, right, the subtle cues of hedging, just to not irritate their patients, right? It actually takes a lot from them. They get so exhausted. I'm just like looking at them on conference centers. Like I can see them exhausted, right? They actually are not excited to see a patient who are taking opiates because they know that they will have to enact these policies. And finding ways to actually ease, right, the cognitive load involved in talking about these policies inside medical interactions would be very helpful. And yeah, that's pretty much everything. Thank you for listening. Hopefully the audio was clear via Zoom. I am taking questions if you have questions. Oh, here are references.